Ready?
Yes, sir. Yeah. You can start, sir. Please.
Yeah, congenital hearing loss. This is a very boring topic for the postgraduates because it's often asked in the exams. When those days when we were doing our postgraduate, it was called as deafness. Now the term is not used commonly, or it was not advisable to use the term. We call this as a congenital hearing loss. Okay, as we know, there are 5 senses, of which it's a vision, taste, smell, hearing, and the touch. If any one of these vision is permanently lost, you cannot get it back, except hearing by the hearing rehabilitation techniques. Right? A permanent childhood hearing impairment is defined as 40 decibel or more average over frequencies of the 500, 1000 and 2000 and 4000 Hz in the better hearing ear. So you should have an hearing loss of more than 40 decibel in the better hearing ear. Otherwise, one side the hearing should be any number above 40, and opposite side it should be minimum of 40 decibel. In the when it's calculated like a pure tone average, how we calculate? Here we calculate 500, 1000, 2000 and 4000 Hz. Hearing loss may be an acquired cause before speech or after speech. A person who becomes a loss of hearing after speech can maintain a little bit of speech, but the person who acquired hearing loss before he starts talking, prelingual, so that patient has got to be rehabilitated very fast. Otherwise, they might permanently lose the speech, because after some years the brain will go for plasticity, and after that patient can't listen, can't hear at all, and so the patient can't talk also. The hearing impairment includes the structural abnormalities in the outer middle ear or a sensorineural hearing loss. Etiology may be congenital or acquired. Here we are going to see only the acquired hearing loss. But this topic is dealt as a childhood hearing loss, which may be both congenital or acquired because of the convenience. Right? The risk factors of the congenital hearing loss are one minute. Sorry. The Joint Committee on Infant Hearing has the following risk factors. Babies which are more than 48 hours in an ICU has 10 folds more chances for the hearing loss. A family history of child with the hearing loss has got a 14 folds increase in the hearing loss. Babies with the craniofacial anomalies like a cleft palate or a tag in the ear, or the patients have got a high risk of hearing loss. You should have basically quantify the hearing loss. So hearing loss can be classified as an average of 500, 1000, 2000 and 4000 Hz on a better hearing ear for us. If it is about 21 to 40, 21 to up to 20 dB, we consider that as a normal hearing. 20 to 40 dB, up to 39 dB is considered as a mild hearing loss. 40 to 69 dB is considered as moderate hearing loss, and 70 and above, up to 95 dB measurable hearing will be termed as severe hearing loss. And more than 95 is called profound hearing loss. This is not the hearing loss what we calculate for our adults, but this is the childhood hearing loss, because the childhood hearing is different because it got to be rehabilitated faster. So there are various, you can take a photograph of this. There are various institutions give the hearing loss as mild, moderate, severe. So there's a WHO, and there is a British Society of Audiology, then newborn hearing screening programs in India, and also an American speech and language hearing program. There's a small amount of difference between each and every one. What we should know more, we should know for sure is that newborn hearing screening program, which takes up to 20 decibel here in India as normal, 21 to 39 as mild, 40 to 69 as moderate, 70 to 94 as severe, and more than 95 as a profound. The same thing what the WHO is what we follow for the adults. So up to 25 decibels we take as a serviceable hearing. 26 to 40 you have a slight hearing loss or a mild hearing loss. We take up to 10 to 15 decibel as normal and 25 as a mild or serviceable hearing. And then 26 to 40 is mild hearing loss and 40 to 60 is moderate hearing loss. Then have a category of 60 to 75 as moderately severe and 75 to 90 is severe. One which has changed recently into severe is 61 to 80 and profound is more than 81 decibels. And the incidents reported are about 1 or 1.07, 107 per 1 lakh children. They increase up to 2.5 among the children of 9 years because there is a hearing loss can occur after the baby is born and can lose the hearing after some time. So 1/3 of all these children of permanent congenital hearing loss have a severe to profound hearing loss. 1/3 of all these sensorineural hearing loss are associated with the vestibular weaknesses. Okay, so suspicion of deafness. There are certain conditions for which you should always think of suspicion of deafness in the children, particularly in the neonates. First is the non-development or delayed development of the speech. Second is inattentive child. The child doesn't concentrate on you, he doesn't look at you, he just there's no eye contact. The patient is inattentive to the surrounding environment. Third is hyperactive child. A child which is very active, you should think of suspicion of, you should think of hearing loss. Then non-responding, when you call, particularly when you are not in front of the child, when you talk with the child, then you should think of hearing loss. Poor performance at school will cause hearing loss, but most commonly that will be because of a secondary auditory media. So, 50% of the people will have a acquired hearing loss, 50% of the people will cause a genetic hearing loss. So, of which all the causes are excluded, then the hypoxia. In a genetic patient, 70% are non-syndromic hearing loss and 30% are syndromic hearing loss. Okay, the non-syndromic hearing loss can be autosomal recessive or autosomal dominant, and then other genetic disorders constitute very small 5%. Okay, so these are all the various causes of the autosomal dominant and the recessive hearing loss. When you go into the causes for an hearing loss, syndromic hearing loss usually autosomal recessive, autosomal dominant, X-linked, and mitochondrial. Non-syndromic also is the same category. The non-genetic hearing loss can be because of congenital rubella syndrome, cytomegalovirus syndrome, first trimester maternal infection, then you have a congenital syphilis, toxoplasmosis, hyperbilirubinemia, low birth weight, birth asphyxia, and drugs during pregnancy like aminoglycoside and thyroxine drugs, and alcohol abuse, of which the low birth weight, birth asphyxia, history of TARCH infections, or the children you got to be early. Okay, these are the children under any first trimester bacterial or viral infection like cytomegalovirus, congenital rubella syndrome. All these patients got to be screened carefully. So the acquired causes may be a perinatal hypoxia, hyperbilirubinemia, postnasal ototoxic drug, trauma, neoplastic diseases, foreign body in the ear, and then immune disorders. Postnatal infections are the chronic auditory media, herpes, meningitis, mumps, misella, toxoplasmosis, varicella, all the diseases which can cause postnatal infection. There should be a newborn hearing screening program is present in most of the developed countries. But in India, there is no structured program like this. Slowly after the advent of cochlear implant, and so particularly when the cochlear implant comes under the Prime Minister or Chief Minister's scheme, these hearing screening programs are coming. So the early diagnosis is the important cause of rehabilitating the congenital hearing loss. So automated autoclassic machines are used in 1 to 4 kilohertz frequencies. Usually it is done from the second day of the delivery. When in our screening program, before discharging the baby, you should look for congenital heart diseases, and then you should look for the vision, and like that. The most important thing is you should do an autoclassic emission and the second year before discharge the baby. For high risk babies, especially one in the NICU, additional automated ADR is done. The result of the screening is either pass or refer. We don't call a fail because sometimes these autoclassic emission may be negative. After 6 months, they may develop because of the delay in the development. But when you say fail a test, the parents will get anxious. So they'll be running from pillar to post, can be misused. So it will come as a pass or it will come as a refer. Refer means you got to wait and do it again. Usually done within 10 weeks. That is, earlier screening, it was less than 6 months have better results. But nowadays, all the high-risk babies, they screen at the first week itself. So what are the hearing tests we do for the children? The key developmental age of hearing and the speech is 0 to 6 months. So what are things we do? We do autoplastic emission, we do para, we do sera, we do measurements of hearing sensitivity. These are for both screening and the diagnostic in the first 6 months. So screening, usually we do autoplastic emission, and whenever there's autoplastic emission, it is referred, we always do a para. Also used to confirm the hearing threshold before cochlear implantation or other non-organic causes are suspected. We do what is called behavioral observation, audiometry. Usually it is done at before 6 months. Change in the activities are observed in response to the sound stimuli. So we will look for startle reflex, eye widening, eye blinking, alternation in the sucking response, arousal from sleep, startle or shudder of the body, the definitive movements of the arms, legs, and the body. All these things are all responded when you do a cranial audiometry. You put a baby on a cradle which is sensitive and give a sound and look for startle. Then you have what is called as visual reinforced audiometry. The key development is the first 5 months to 36 months. So it's incorporated the principle that the young children can be trained by an operant to produce a localized turn when the visual stimuli in response to a stimuli. Okay, so this is set up like this, and you distract the patient, and then the patient sits on the lap of the parent, and then you have two speakers, right side one, left side one, and visual reinforcer. You get some coloring bulb or things like that. You have a load table. You distract the patient so that patient doesn't follow the change, because when the patient's eye is used, they listen only to the sound, and then you have a tester which sees the response. Okay, so then okay. So what are the pitfalls? The behavior observation audiometry, visual reinforcement audiometry, and the distraction testing are all can be positive or negative, depends upon the patient's state of mind, how much they got distracted or how much habituation has happened. So there is the pitfalls are attempting to condition a subthreshold stimuli. Okay, visual tactically, when you make a sound, the sound waves are there. You can have a tactile stimuli, or the baby can see in spite of the distraction, or you can take the clues from the parents distracted or a second tester. So it's called checking response. I know one of my close friends, he had autosclerosis. He was at the age of 17, 18, got operated. So he came to the audiometry room, and then that audiologist explained everything to him. He said, no, he hear the sound, he could lift the finger. And then he sat there and he had eye contact with my friend. He lifted. Then he came in there, this stupid, tell me, when you hear the sound, not you don't look at me. This happens. When it happens for a grown-up people, it will happen more for the children. Then sometimes they want something else to do, and you want to check their response will be very poor. Okay, so you got to keep all these things in your mind and manage accordingly. So you got to casually increase the intensity, and then you should give a no sound trial like what he has done, and there is the sound stimuli. Few people are interested by the different sounds. Okay, so you got to calibrate the sound source and measure accurately. Use the sounder test room with ambient noise less than 30 decibels. Okay, then 3 years onwards you can do a pure tone audiometry, and then auditory speech perception test. You have a speech audiometry to look for speech perception threshold and the speech detection threshold. And the speech discrimination test is from 30 months you can do the test. Okay. 4 investigations for the case of bilateral sensorineural profound investigation say first you have a good pediatric history, detailed history of the pregnancy, delivery, and the post-SLPA. Developmental milestones where there is a decreased development, including speech, language, motor milestones, pre- and postnatal noise exposure, history of autotoxic medication, head injury, ear diseases, meningitis. You got to always keep in your mind that meningitis produces cells in your lungs and viral infection. And you should ask for an immunization status. Family history, you should always look for deafness in the family and consanguinity. Factors associated with the hearing loss in the first and second degree relatives. Okay. On clinical examination, you got to examine the patient's, you got to inspect, measure the craniofacial measurement, assessment of the neck, skin, nail, limbs, chest, abdomen, and you do a developmental examination. Audiology, according to the age, appropriate assessment including tympanometry, audiometry, and the first degree relatives. Imaging, you do an MRI and you do a computerized tomography of the fetus apex bone. Okay, then you do a ECG. These are all the tests you do for screening for the hearing. Doing microscopic hematuria and CMD, DNA, PCR in the neonatal conductive hearing loss. Cognition 2630 mutation testing is, if it's available, it got to be done and you got to counsel. Ophthalmic assessment is very important because certain diseases will have a progressive loss of vision. So, retinitis pigmentosa. So, you got to be careful that if those patients, you got to rehabilitate the speech and the hearing before the olfactory loss sets in, because you are going to give the cues for the patient to hear only through an ophthalmic. You want to tell the patient that you got to show the red color and tell the patient don't hear, rehabilitating the patient will be very difficult. Then you should always get a genetic opinion. Then you do a vestibular investigation, then CME serology. Medical management consists of developmental assessment and coexisting medical condition got treated and investigate for the cause of deafness. How might your hearing loss evolve, and this in turn alleviate the uncertainty? Is there a genetic factor for the patient or parents care or carers? They can be counseled for genetic point of view also. Okay. The aim of the etiology investigations are try to provide a reason for deafness, identify the conditions that may affect the audiological or medical management, to provide better advice to the patient with regard to the best management of associated conditions, and to assist the family in making educational management decisions for the child. To inform genetic counseling and inform the epidemiological research. Okay. So history, clinical examination, audiological examination, imaging, blood tests, urine analysis, serology, ECG, and genetic screening, all the support we should give for these patients. Okay. So pediatric hearing implants. So how do you implant a patient? Implantation of a hearing aid with children including two broad groups. One is electrical hearing with a cochlear implant, acoustic hearing with the bone conducting implants, silent sound bridge. Okay, so the family with the profound sensory hearing loss implantation is always preferred. Okay, so cochlear implant. These are the auditory implantable processes that electrically stimulate the spinal ganglia of the cochlear nerve directly in circumstances when the cochlear air cells themselves do not function effectively to give a adequate speech intelligibility. They consist of an external device with a microphone and a processors, an internal device with a stimulator and the stimulator of the cochlear nerve. So the cochlear implant is the only device which regains the lost hearing loss, which is one of the important sense of the five senses in the man. So a cochlear implant is a very costly affair, and you can't do it for all children. Then Government of India and the Tamil Nadu government has included cochlear implant in this insurance scheme, so that whenever the baby has got a cochlear implant, which is before 5 years, they do the implantation with free of cost. If it is below 7 years or practically below 8 years, they do it after getting a special permission. So this is the inner device. So this is the electrodes. There are 12 pairs of electrodes are there, and then you this inserter. Then you have a magnet, and then you have a receiver induction coil, together located at the outer transmitting coil by the magnetic attraction. This is the processor, and then you have a electrode. So can you see can you see my arrow?
Yes, sir.
Yes. So this is the magnet, this is the processor, and this is the electrode. So the tip of the electrode, this one should go inside. Okay. So the electrode can be modular or cochlear contour. The contour is the mid-scalar electrode, and there's a lateral electrode like medal, what we are using it here. We've got a rigid one and a flex one. The flex one is the one which is very, very flexible, easily goes inside, and usually position the electrode within the scalar tympani, and it sits close to the nuclear element. So scalar tympani is closed by the tympani, which is nothing but the round window. So you can put an electrode in the scalar tympani by making a hole in the cochlea. It's called cochleostomy, or you can push it through with the round window membrane, which is called the round window incision. There are bone conduction hearing implants, which is usually used. It's called BAHA. So these are all used for the conductive hearing loss. So the people at the very small ages, you can't rehabilitate the hearing without doing an external device. So for example, a patient who has got bilateral CSOM, patient who has got mitosia, you got a hearing loss, and other causes like atomic cortex media, articular pathology, discharging ear, unilateral profound or severe mixed unilateral profound mixed hearing loss or a secondary hearing loss, and the conventional hearing aid, you give a bone anchored hearing aid, and the child is not willing to wear a bone anchored hearing aid, then you got to give a bone anchored hearing. So this is the BAHA, where you have an also integrated screw. You integrate the screw and fix this is called abutment. This is made up of titanium screw. This is an attaching fixture for an hearing aid. So this is the skin, this is a bone. You make the hole in the bone and fix this abutment in such a way that it fits with the external canal, and you fix the hearing aid attached to that by putting a screw. This is the hearing device which can be fixed with this, or it can be. So this stays in the body without any reaction. Okay. Then There are other hearing devices like a midbrain implant. When there is a bilateral neural type of sensorineural hearing loss, or when you do a cochlear implant, when you do a bilateral acoustic neuroma, you cut the nerve, then you should plan for a auditory brain stem implant. Okay, but one thing you should keep in your mind that implant is the ABI patients perform poorly compared with that of the cochlear implantation. So always, whenever there is a possibility, do a cochlear implant. Unless you cut it out, it's always preferable to do a cochlear implant than do an ABI. Okay. So when the baby comes with the hearing loss, all the babies who born should be screened with the autoplastic emission. So you do it within 6 months and then you wait. So 6 months after doing the test, if the test fails, then you got to redo the test. Still the test is failed after 6 months, then you do a ABR. ABR is also done for high-risk babies in initial workdown itself. Okay, so you do a OAE and a BARA. Then with this we have to say, so failed children referred will undergo an audiological evaluation. So what all why you should know this is, today you can empanel the hospital with a cochlear implant, with a CM scheme, and then you can send all your documents to them to get the authorization. To get the documents, what are all things we should have? So for the screening level, you do an autoplastic emission and you do a BARA. The BARA is BARA and autoplastic emission or OAE alone is negative. Wait for 6 months. After 6 months, you redo again. Still, it's both the things. There is BARA, there is no threshold or a very severe hearing loss, and then there is no autoplastic emission. Then you should work up the patient for cochlear implant and talk with the patient. Okay. So first you do a free field audiometry or a pure tone audiometry. This should be a bilateral, severe to profound sensorineural hearing loss. OAE should be absent outer accent. You do a deep OA, which will be absent. Okay. Then you do ADR. So there will not be no response at the fifth wave level, even at the suprathreshold level, which implies profound sensorineural hearing loss. We do it even to a 60 decibel, 70 decibel hearing loss both the ears. Then you know the hearing loss, aided audiogram doesn't come inside the speech banana. You can plan to do a cochlear implant. All users should have a speech language pathologist. A speech response got to be evaluated correctly. Then we have to subject the patient for a hearing aid trial. So hearing aid trial is done, and then you take an audiogram. It's called an aided audiogram. The aided audiogram response should be outside the speech spectrum. You have something called a speech banana, which will be a spectrum of the hearing capability, where in the 500,000, 2,400 frequencies, between the 20 decibels and the 550 decibels, you have a hearing that looks like a banana. If it goes outside, then you can take up the change. A realistic expected cochlear implant can be counseled for the patient. If all the above audiological evaluations are is positive, then this is the patient for cochlear implant. So you can't send this patient directly for cochlear implantation, because they need certain things. They want to know that patient has got good brain development. Why? What's the point when the patient's brain is not developed, and severely MR patient, hearing or not hearing, not going to help them much. The thing is, because government is spending so much money, and then they want the result, and this money should go for the good people who will get benefited with this money spent on them. So you want to know whether the patient has got psychiatrically normal, whether the patient has got brain development is normal, and patient doesn't have any severe diseases. Like there is a condition, JW syndrome, where there will be a QRS time will be more, the patient can develop arrhythmia, so you got to do an electrocardiogram. You can't do these surgeries, particularly when the patient has got a secretory arteries media or the patient has got a future chance of developing cholesteatoma. So you got to take an X-ray nasopharynx or a CT nasopharynx to look for adenoids, take an X-ray chest for anesthetic assessment. You got to do a RFT, renal function test, liver function test, and serum electrolytes. All these tests are all done. Serology, torch infection, total complete hemogram, bleeding time, clotting time, INR, blood opinion, cross matching. All these things are all done to see whether the baby has go to the right hands for the cochlear implant. Okay. So then you do imaging. You do HRCT temporal bone. In HRCT temporal bone, you should look for a normal development of bony cochlea. Okay. Then you should look for vestibulocochlear nerve, the present normal sized vestibulocochlear nerve. These two things you should be very careful when you are trying to evaluate the patient of the cochlear. Okay. So all these patients should have an MRI, all the patients should have an HRCT temporal bone. In the HRCT temporal bone, they will see whether any rotated cochlea, the 2.5 turns of cochlea is present, or whether the patient has got a single cavity, the partial partition problems. All these things they will look for. What should they look for? They will have centers which are all started doing implant now, or the centers which are well versed in doing the implant. Because this is only a government money which is going for an institution, when they see a patient who has going to a place where there is a chances for the implant is not there, those people will be referred to the places where they can do that. So here you can see the cochlea, all the chambers are all normal, and then when you look at this is most important one. You look for all four nerves. You have a superior vestibular nerve, you have a facial nerve, an inferior vestibular nerve, and a cochlear nerve. So all the dots, and you should measure they will measure the nerve thickness to find whether the nerve is dysplastic or aplasia of the nerve. Whenever there is no nerve on both sides, there is no point in doing a cochlear implant. Okay. So then they measure the length of the cochlea, because when you have a long array and a short array in the cochlear implant. The short array is used when the cochlea is rotated or the length of the cochlea is small, because you can't. When you take a normal implant, it will not all the electrodes will not go inside. Then you should. Other important thing is you should look for patency, because the syphilis, labyrinthitis will cause the bone formation, so that the hole in the scala tympani will be narrowed or sometimes be lost. Those conditions you can't insert the implant. Okay. Then you got to get the opinion for cardiology opinion, psychiatric opinion for an IQ testing. I told you the patient should have a normal IQ to do an implant. If the IQ is very, very less, whatever amount of sound they hear, he will not comprehend. So the effective results will not come. Then you get a neurosurgery, neurophysician opinion. Then you get a pediatrician opinion to rule out other congenital anomalies, and other congenital anomalies which are life-threatening. Okay. Then you want to do a vaccination for two things. One is a pneumococcal vaccine, meningococcal vaccine. We have done in the past 8 months, 8 weeks, in the 2 months, we have done about 35 cochlear implants. But we have not vaccinated corona. But maybe in future, once the guideline comes, we may give a shot for corona also. But pneumococcal vaccine and the meningococcal vaccine are very, very important, because the pneumococcal infection can cause life-threatening complications. So then you go to send the patient for a cochlear committee approval. If you get a patient, you have access. If you are already a cochlear implant surgeon, you got a mentor, and you are doing it outside. And when you get a patient, you can pay. That's fine. Otherwise, you got to send the patient for cochlear implant approving committee. This happens on the every third week in the DMS office, TNHS office, where they will do the checking up all these things. So they will check up whether the patient is not getting improvement with the hearing aid. Otherwise, the hearing audiogram is not in this is speech banana. They look for threshold, particularly a better threshold, and then they will check up for the all other investigations like any other how is IQ of the patient, how is nasopharynx, and how is cardiac status, all these things they will check. Then the candidacy will be approved by the approving committee. Okay, once it gets approved by approved committee, you can do an implant for the patient. So how do you do the cochlear implant? So cochlear implant, first thing what you do is you should plan your incision. You're going to keep a big device behind the ear, so that when you suture it, the device should not bulge out. So to prevent it from bulging out, you got to make a crater. So the crater, but in babies they'll have a very thin bone. So when you drill it, immediately you get the dura. So how much ever of weld you create and keep it there inside and suture it in such a way that it will not come out of the bed easily. That's the first thing. Second thing is you got to plan an incision in such a way that the incision should not fall directly on the implant, so that there will be a bulging implant which can cause wound dehiscence. Once the wound is dehiscent and there will be a biofilm forming, the implant will not work and it will extrude. So you got to be very careful in planning the incision. Then when you elevate a skin flap, the flap got to be thick. You should have a thin skin flap, and also you should have a flap for the periasteal flap. So this flap will close properly. Otherwise, there's a chance for giving away. Then you can get an extrusion. So once the biofilm is formed, usually you got to explant the patient, and it's a huge trouble for the patient. So you got to be very careful when you are planning the incision. Once you make an incision, you elevate a skin flap, you elevate a periasteal flap. The periasteal flap can be anterior based flap, inferior based flap, posterior based flap, or any flap, provided the flap should cover completely, and usually it should not be kept, the suturing site should not be kept close to the future implant site. Okay, then you do a cortical mastectomy. So the cortical mastectomy will be very easy surgery, but most of these babies, because they are babies, you can see the corner septum. If you have started doing implants, corner septum, you will not get filled. Yes, it will be there. Okay, and then you got to identify the incus. Can you see the video? Can you see the video?
Yes, sir.
Yes. So, this is anterior, this is external canal. The most important thing is you should never enter the external canal, because external canal is the area which is full of infection. So once you enter the external canal, you will expose the implant outside. So the chances for explantation is very high. So you should never enter even if it was facial injury, it's acceptable to an extent, but not the going inside the external canal. So this is your external canal, this is your tegment plate, this is your sinus plate. Then I am opening the mastoid, so next time I have opened. Then this is the corner septum. I am opening the corner septum now.
Our number is our number.
You can see this is a cell, the whole thing is a arthritic plate. This is a corner septum. Okay, can you see here? This is here. This is the septum. Can you see? So then you expose the incus. Why you should expose the incus completely? You should see the fossa and cutis. The tip of the incus will tell you the course of the facial nerve. Just anterior to that will be your posterior temporal artery. So this is the line of the facial nerve. The tip of the curve will tell you where the facial nerve lies. Okay. So once you have opened the incus, you should do a posterior tympanotomy. Posterior tympanotomy, so when you do a posterior tympanotomy, you should keep the incus in your vision. So this is the area. This line will be your facial nerve. If you get used to it, you can see the facial nerve. Before opening the facial nerve, you know it is the facial nerve. But till then, you have to be little careful. So open up the posterior tympanotomy. Posterior tympanotomy is the cauda, fossa anterior, and the facial nerve. So posteriorly facial nerve, medially facial nerve, laterally cauda tympanic annulus, superiorly the fossa anterior. Okay, in the fossa anterior you have the sharp cross of the incus, which gives you the idea of where the facial nerve is. Then you keep drilling. So drilling should be in such a way that when you want to drill an area, the side of the burr should not touch both the walls. If it touches both the walls, it will injure any one of the walls. For example, you take when you go to a sinus tympani, facial recess, when the burr is this big, you can always have trouble. You can always have trouble in always on trouble injuring the facial nerve because the side of the burr, you think the tip of the burr is operating, but the side of the burr can injure the facial nerve. Okay. So selecting the side of the burr is very important. And you should keep the posterior canal wall paper thin. It's like a paper. Then only you get a good implant. Very rheumatized mastoid is trouble. Sclerosed mastoid is also trouble. If mastoid is little bit rheumatized, that's an ideal case also. Okay. So this is called incus buttress. So you see a small spool. Once you see this is your entering place for the middle ear. So what happens when you put water here, you can just suck it from here. Posterior tympanotomy. I always prefer doing posterior tympanotomy and the opening of round window. You can see the round window.
Yes, sir.
Yes. So this is your facial now. This is round window membrane. Okay. So whenever you do, when you open up in a small area, you want to drill the round window niche, or you want to drill entering the middle ear through a posterior tympanotomy. Never use. Always don't use a diamond burr because diamond burr produces a lot of powder. This powder can block the underlying cell or underlying opening so that you might miss it. Okay. Then you got to open the round window. This video will tell you how to open the round window. Okay. So this is your round window. So you can see the facial nerve here. That's a facial nerve. Okay. This is a skeeter burr. With the skeeter burr, you open the anterior lip of the round window bridge. So once you open it, you see the membrane. You can open the membrane now itself, or you can open the membrane later. So this is the round window membrane, the starting of the, or rather end of the sclera tympani. Okay, so this is the round window niche. Then you keep a small amount of gel from there. When you go and make you got to drill the you got to drill the bed for the implant. So they will give you a dummy. So the dummy will be in plastic and look exactly like a cochlear implant. So you try to keep it in the skull, select the area where you want to keep. Then take the fissure bar, make a line, so that you know where are you going to drill it. So you make all the four walls dry. I mean, all the four walls you draw on the bone with the fissure bar. Then you make the this thing. What do you say? You make the and you make two holes on the sides. The holes can go. You can keep some protection and make a through and through hole so that you can take the this thing through that. You can take the suture material through that, or you can make two openings so that the intake active opening you can make it on both sides and then you can tie it up. Okay. Once you have done that, you got the insert. Inserting cochlear implant is like placing the piston after separation. You always think that placing piston after separation is very, very difficult, particularly when you are doing for the first time. But when you keep on doing that, slowly it will become like you will be doing it just like that. So cochlear implant also, once you have done it enough times, you can do it simply. Okay. This is one of the cases I did recently. The tip will be, this instrument is called jewelers. Like the instrument what the jewelers use to take the gold. So this is called a claw. You take a jeweler, so put it inside the hole what you have created, and then with a claw or a jeweler, slowly put it inside. Okay, you see a marker here. Till that marker you got inside to keep all the electrodes inside. So this is the marker. You keep it inside till the marker has gone. You got to be very careful. Suddenly it will come out also. So can you see? The implant goes up to the marker. Okay. So once it's gone inside, you can see it is there inside. Then you take this pieces of the excess to, before we start the case, you got to put you will take a small amount of small seal, tissue seal. So that seal got to be kept inside. You keep the implant inside the cavity. So this is the see the thread. The thread is tied to keep the implant inside the cochlear implant. Then you bring the implant this thing and keep it inside the cochlea through the round window membrane. This is about the cochlear implant with the round window membrane. Sometimes you don't see a round window. After some time you do a cochlear implant by the round window of the medical college. So what they do is, so this is you can see this is incus is mobile. So when you want, so this page I couldn't find the round window, round window opening. So we do a cochleostomy. So cochleostomy is done inferior and anterior to the oval window. So this is cochleostomy. So you take cochlea through a cochleostomy. You try to insert all the 12 pair of electrodes. Once you have done that, you keep the this thing C, and then fold the electrode and keep it under the particle. Okay. So that it will come out easily. After all these things over, you got to switch off the wound. And then give a good antibiotic for about 12 days. It will become alright. So post-operative follow-up, you will switch on the patient. Switching on is at the 21st day, you got to make the cochlear implant work. So what happened? Baby has not heard any sound so far. Suddenly you start hearing sound, you get irritated. All of you have seen a movie called Waterworld, where that man who comes to the sound, comes to the land, will tell, the land is full of sounds, I don't like, I want to go to the water. The same way, the baby will not like the sound is going to come first. Then you got to slowly give the speech therapy. The speech therapy you got to give minimum of about 2 times a day. You remember, the baby will not talk as soon as the baby is born. It will talk only after 1 year. Similarly, this baby also will talk after 1 year, provided you give a good speech therapy. Okay. The switch on will be done only for few frequencies and low sounds. Slowly they will increase the sound so that what the low frequency, low sounds she heard, slowly she will hear the other frequencies and other intensities also. Okay. Then frequencies will be increased slowly. So that patient will start hearing everything in future. So this is how you do a cochlear implant in the government setup. Thank you very much for the opportunity. Dr. Professor Mariappan is my MS classmate. He's a very good friend of mine. He's got a keen interest on audiology. Even those days he used to do a lot of mass alectomies, and his interest will be mainly concerned in the audiology. So, in a World Hearing Day, it's my honor to talk in front of you and share a little bit of things what we do in Madras Medical College. And I think the team, the wonderful team there in Manakula Vinayagar Medical College, will try to empanel their hospital also